Now moving on, as we are dealing with the primary malignant bone of the tumors, then there are also malignant after going from bone to hematogenous malignant tumors, then coming to the soft tissue. Now there is another adipose tissue which is present in our body as well, and then there are tumors which is called as liposarcoma, which is actually a malignant form of tumor of the adipose tissue. In this section, we'll be going through the lipoma and liposarcoma, and the next we'll also be going through the peripheral metastasis disease. That is, usually the tumor is not in the bone, it's not a primary bone tumor, it's either in the breast, it's either in the thyroid, it could be in the lungs, it could be in the kidney, and it could be in the prostate. But they usually either present with a lytic or a blastic lesion in the long bones, or they may present with a pathologic fractures. Then how to go about it, how to work about it, and how to deal with a malignant metastatic lesion in the long bones. So what are lipomatous tumors? As we know, the lipomas actually body contains an adipose tissue, which are actually formed of fat cells, and these are called as the benign variety of this is called as lipomatous or lipomas. They are usually benign and superficial. They rarely intramuscular but can be intramuscular. Classically, they present as painless, mobile, slow-growing lesions, usually over the long bones, or especially over the areas such as scapula and shoulder area. They are X-rays. They usually appear completely extraosseous, that is, they have no involvement with the bone area, and usually not involved or attached in any form with the capsule as well. On MRI, their appearance is usually homogeneous mass, which is actually seen growing in either in the soft tissue or in the peripheral region. The commonest sign is actually the slip sign. That they're highly mobile, and as you examine them, it's like a running mouse, and they just move from there or there. And the treatment is usually marginal excision, that is, all the mass which is actually present is simply taken out with no radiotherapy or chemotherapy needed, as it is benign tumor. But liposarcomas, it's actually sarcoma of the this adipose tissue, and they are malignant. So it's low to high grade, although rarely metastatic, but the one point is their malignant potential. They're usually atypical lipomatous tumor, which could be as high as in 40% of the cases. This is a subvariety which is called a dedifferentiated liposarcomas. This is why it's important, because they usually present with retroperitoneal masses. And when working for retroperitoneal tumors, one of the things which is must become differential is dedifferentiated liposarcomas. As they are malignant, so the option is to go for wide local resection, radical resection, followed up by radiotherapy and chemotherapy. For all malignant tumors, not only resection is required, you have to follow it up by radio and chemotherapy. For low grade or for benign, only resection probably is enough for these tumors. Now the differentiation is actually by MDM2 amplification, on which can be appreciated on fluorescein in situ hybridization, and usually FISH is positive for these liposarcomas. Now coming to the metastatic bone disease, sometimes patient comes to you, let's suppose 40-50-year-old female, and sometimes comes to you with lytic lesion, or let's say pathological fracture of the proximal femur or subtroch region. Then whether it is the primary bone tumor, whether it's involving something like subperiosteally area or subtroch area, or whether it's metastatic disease, then that has to be differentiated. How do we differentiate? Actually, it's metastatic bone disease is termed as transmission of pathogenic microorganism or cancer cells from original site to one or more sites elsewhere in the body, usually via blood vessels or lymphatics. And most common route is usually the hematogenous spread or blood vessels. Clinical features usually pain, swelling, or pathologic fracture. These are classical presentation. And classically, it's mostly pain is nocturnal, that is night pain associated is out there. If that tumor has actually spread from, rather than going to the long bone, it goes to the spine, sometimes it can present with not only pain but spinal cord compression symptoms and hypercalcemia of malignancy as well. How would the symptoms occur? There will be anorexia, nausea, classical symptoms of long-standing malignancy or cachexia, thirst, polyuria, and abdominal pain due to hypercalcemia, There may be weakness and depression. This also linked to the hypercalcemia of malignancy, which may be associated in these diseases. Now, how we analyze whether if the patient comes with a lesion, usually the first thing is the age of the patient, whether is this patient's age is a 40, 50 or a young age, and then whether this is male or female, and then the next is whether the lesion is lytic or blastics. Some lesions, for example, such as breast tumor and prostate, they are classically presented as blastic lesions, but in case of thyroid and renal, they could be presented as lytic as well. Where in case of lung tumor, if it metastasizes, it can present as lytic as well as blastic lesion. So the first thing we have to decide whether it's a malignant region is usually bone destruction and increased tumor burden would be seen. There will be secretion of factors such as TNF alpha, interleukin 1, 6, and parathyroid hormone related peptide, which is actually classically seen in hyperparathyroidism due to parathyroid adenoma. Prostatic lesions are usually osteosclerotic or osteoblastic, along with the breast lesions, while lung and breast metastasis could be osteoblastic or osteolytic. Usually, lung is mixed, breast and prostates are blastic, while thyroid and kidney lesions are usually lytic. Then, how do we make the diagnosis? The diagnosis starts with the history. Was there any associated history of mass, pain, or anything? Was this associated fracture associated with trauma or not? And if there was no trauma and suddenly the bone broke, probably this is candidate to pathological fracture. And if it was a pathological fracture, then we have to know the age of the patient, whether where the fracture has occurred, whether it has occurred in the subtroch region or in the proximal humerus or where, and then whether it's a lytic or a blastic lesion. That will point out to the specific type of metastatic disease. The next workup which is could be done is the bone scan to assess for other lesions, whether it's multiple or multi-osteotic lesion or single lesion. Then it will also give us a clue whether where is likely the primary be. And the second is usually it's the other option is CT scan of the thorax, abdomen, and pelvis is always done to rule out where was the most likely the primary would be if this lesion is metastatic lesion which is coming into the bone or spine. The next could be the MRI as well. If depending upon what if we are not sure about the diagnosis, we can also go for SPECT scanning to evaluate whether underlying what is the cause of this lesion. Then lastly, once we have identified most likely what is the primary lesion, then we can go for the biopsy of either the metastatic lesion, or we can also go for the biopsy of the primary, depending upon what are we suspecting. If we are suspecting, for example, lung, then we would probably easily take it out via the lesion. We can make sure the biopsy is taken from the lesion which is in the bone. But if we are suspecting renal cell CA with a metastasis to long bones, then before taking on a biopsy, we have to get an angioembolization of the area, so that because otherwise this biopsy is gonna bleed like anything. So depending upon what type of the lesion is, where it is going, we have to initially the history, then examination, then coming to the investigation. Then from investigation, it's always the non-invasive first, then the invasive, and eventually going toward the biopsy to confirm our diagnosis. And once we have confirmed the diagnosis, then starts the treatment regarding that possible disease which is underlying problem or the disease which has actually metastasized to the bone. Then treatment options depend upon whether it's from the breast, whether it's from the lungs, whether it's from the thyroid, from the kidney, or from the prostate. If it's from the breast, other options could be hormonal therapy or bisphosphonates. Then if it's from somewhere else, it could be chemotherapy, depending upon where it has actually metastasized. Biological targeted agents, especially for example tamoxifen, has a very high role in breast CA. Radiotherapy is for in case of breast CA. Nowadays radiotherapy is also not done. Rather, brachytherapy, which is a form of in situ radiotherapy, is actually done for prostate CA. But if we know it's prostate, then we can go for radiotherapy in that case. And if we are not, for example, it came out to be renal cell CA, then probably yes, we have to go for angioembolization. But probably the main treatment would be surgical resection, either partial nephrectomy or complete nephrectomy, depending upon the stage of the disease, along with the pathological fracture fixation which it has presented with. In this section, we have gone through lipoma and liposarcoma, and we have gone through how to deal with a metastatic disease of the bone. The treatment always starts from the history. We have to know what was the age of the patient, what were the symptoms, whether it's a pathological fracture or it is a traumatic fracture, whether this lesion is lytic or blastic, what is the age of the patient, was there any history of previous radiotherapy or any history of previous CA, or is there any family history of CA. Then depending upon how the history and examination evolves, we have to get non-invasive test first. All the CT scan, MRI, and SPECT and bone scans can be done to make a diagnosis, and then the biopsy can be done to confirm the diagnosis of disease, eventually leading to the management which is required for that particular CA which has metastasized to the bone. Thank you very much. Keep watching sqadia.com.